just to say that I'm now working with Cleveland Clinic London, and we've opened our outpatients in 24 Portland Place, and it's going really well. And we look forward to opening the hospital at the end of January next year. And this slide shows our mission, vision, and values and principles. And my experience, having worked with them for several years now, is that they really live by these, and that the values of quality and safety, teamwork, empathy, inclusion, integrity, and innovation are held very dear to them, and that they do indeed treat patients and fellow caregivers as family. And here you're a caregiver, whether you clean the floors or you're a professor of pediatric neurosurgery, and they really do adhere to those. Let's take the slides off now, please. Thanks, Judith. So over to you, Jim. If I could just start with a few questions. So tell us about where you grew up and your early years.
Hi, Richard. Yeah, just first of all, I would say that. Oh, hang on, sorry. I remember that day meeting you and Al very well, and I particularly remember hearing Mr. Windsor say, why do I have to do this nonsense? I've got an anaesthetist who does this for me, and you just saying to him, come on, Al, just do it, just go through the motions. And I thought, oh, I'm going to get on with these two. But yeah, no. So I'm from the West Country originally. I grew up in a medical family. My dad was a gastroenterologist, and had one of those, and a sort of general physician, had one of those, you know, DGH practices where he did everything and for everyone really. And I grew up with him seeing patients at home. I remember being very disturbed when I discovered that the long metal thing in the bucket outside the back door was well, what it was. And then I just when I was about 18, did some work experience with him and decided to do medicine that I'd been determined not to do, and studied in Bristol, and then came up to London as a sort of senior SHO and never left.
So what was it that convinced you to become a first of all, I presume you became an anaesthetist first, and then what stimulated your interest in critical care? Just to sort of set the ball rolling, whenever anyone asks me why are you a colorectal surgeon, I say, well, I like doing stuff that no one else likes to do. So what pushed you into doing anaesthesia and then critical care?
Well, I mean, there was partly I thought I'd be a GP, and then I realised I just couldn't talk to people that much, and so in some ways I went to the other. I mean, I didn't quite become a pathologist, but I suppose I went to the next best thing with the patients being unconscious, and I quite liked the sort of immediacy and the sort of back to basics element of it. So I quite like the fact that you could manipulate physiology in front of your eyes, whereas I found the medical sort of drop down menu list of diagnoses much more difficult to cope with. I've lost. Oh, there you are. And I was never going to be good enough with my hands to be a surgeon. I can't believe I'm admitting that to you. And then it was only again halfway through my training, I did some ICU at Middlesex, as it was then, and was around this quite an inspiring bunch of sort of pioneering intensivists, and they really you know, pushed me forward to do that. And now I'm very pleased I've got the mix really. So I have my weeks of very busy ICU, which I suppose I could do a bit more sleep on those weeks, but otherwise, you know, they're very stimulating and sort of chaotic, and then they're counterbalanced by the time the operating room, which should be generally more in control.
And you've increasingly moved into critical care, haven't you? So I get the impression, and that seems to be a well-trodden path. No one ever seems to go the other way. So most of the anaesthetists I know who have an interest in critical care tend to sort of migrate into it. I mean, is it the proctology of anaesthesia? Is it a nice life in critical care? I always thought it was really tough.
I don't think it's well. Interestingly, I think it has an image of being tough, and it can. It certainly the nights can be you know, busy, and I think people, you do it, you know, it becomes your, I'm sure it becomes more of your focus because you're doing less anesthesia, your skill set sort of narrows a bit, and so inevitably it becomes your, because it's your sort of specialist interest. I think also, you know, as a specialty, it's been growing even in my career. So it's you know, when I started, you couldn't become just an intensivist. Now you can do your whole training in just intensive care. So it's growing all the time. So I think whereas it used to be anaesthetists just doing a bit in their spare time, it's becoming its own thing, and so we're all trying to catch up with it, I guess.
And I know you've worked with some great people who I know as well. Who would you say was the biggest influence in your either or actually tell me, in your anaesthetic and in your intensivist career so far, who's been your biggest influence?
Well, yeah, I mean, it various things. I think my biggest sort of medical, if you like, influence is probably Merv Singer. I don't know if you know Merv well, but he's a huge character of the specialties. He's a little bit mad. He's wildly clever. You know, one of these people who doesn't really sleep. But he's also just a delightful man. And despite being probably the biggest name in the country in the area, still has time for everyone. And he's just one of those sort of magnetic teaching characters who's read everything. So he's quite nice to have around, because you know, if you ever need to know if there's a paper on something, he's already read it. Anesthetically, it's interesting. I did a survey of the department who we'd like to anaesthetize us, because I felt that the top clinicians, you know, I don't know if this is the case in your world, but the people who publish always get lots of accolades and you know, awards and things, but the guys you'd actually want to look after you tend to be slightly forgotten. And the chap who came to the fore, who you'll know, I'm sure, was Wyn Davies, who's sort of wonderful. He's just retired, but he was when we were all growing up, he was our mentor, our teacher, and he's the person, when it came to us, who had to anaesthetize all of us, which I'm sure has been very stressful for him. But yeah, so he was a big influence. As a registrar.
He delivered one of our babies, cesarean section. He sort of gave Madeline her epidural. I suppose it's like the surgeon. So the anaesthetist is would be Wyn Davies.
And Marn, actually, your old mate, he was the other one who was clearly brilliant at it, and was very popular. Interestingly, he was very popular with the ODPs, who probably know more than we do about who to choose. But yeah, no, Wyn did our kids as well. He's done probably most of the departments, I imagine.
If it's any consolation, Jim, if I had to have an anaesthetic and I had the choice, I'd want you to put me to sleep, because I know that when I had the ensuing cardiac arrest, you know how to deal with it, and then put me on intensive care.
Well, you've already done my colonoscopy, so you know that the feeling is reciprocal.
I've erased that from my mind.
Sorry.
I was certainly asked to be looking on, and certainly if I was very unwell as well. I think the critical care service that you and your colleagues run is second to none. Just tell me, can you think of an example of a situation, or a particular situation, or a type of situation that you find most difficult to deal with, or have found the most difficult? Do you have an anecdote, or is there something that springs to mind?
I think, well, there's a mixture on there. I think the you know, clinically, I think we're all obsessed with the failed airway. I think that's in the back of our mind. There's this strange thing about anaesthetics in ICU that which is sort of unique in medicine, I think, where you take someone who's well and render them helpless, and then, you know, rescue it. Now, of course, 99.9% of the time, that's absolutely fine. But we all, and we use techniques to try and mitigate it, like in all areas. But I think we're all right in the back of our minds aware that when you deliver that muscle relaxant, you've got to be able to oxygenate. You know, I've not had the catastrophe, but of course it happens. You know, it happens every year somewhere. So I suppose that is the sort of the acute clinical thing that's probably gives gives anaesthetist grey hair. I think in ICU, it's a slightly different thing. I think it's more the more you do it, the less you know, kind of thing. And I don't know if this translates, but the more you see, the more cases you see, the less sure you are about when it's hopeless, when there is hope, how long to carry on, you know, what is a meaningful life, what isn't, what, you know. We all came with our prejudices, and I've just found that mine have been gradually eroded over the years, yeah, and so I suppose it's that really in the ICU.
And that brings me on to, I'm going to shamelessly show this is the book that Jim has written, which I read and I enjoyed, which was about your experiences during the first COVID lockdown era. And in fact, just to start the ball rolling, I remember back in March 2020, I came back from my skiing holiday and I was on call for a week. And we always used to have those big huddles where we would get together and discuss cases for the day. The emergency, which consist of surgeons, anaesthetists, intensivists, all in the same space of 2 meters on top of each other, as it were. And as a result of which, I stood no chance along with some of my colleagues and went down with COVID. But I remember we were sort of discussing this odd disease, and we knew that our colleagues in Italy were having a terribly hard time, and no one seemed to be taking it particularly seriously around the world. And then it hit us, and you and your colleagues provided the most amazing service on intensive care at UCH. And whereas the surgeons, we used to be the kings of the roost in hospitals, we were unable to work because it was said that if we operated on a patient that got COVID, the mortality was 1 in 4. And the intensive care doctors and the anaesthetists suddenly became the most important people in the hospital, much to our shame and disgust. There you go. And we were put down to. I mean, I came in, as you know, we turned patients on their faces and on their backs in ITU as teams to help you guys do your wonderful work. Tell us a bit about it. How did it start for you, and tell us some stories about it.
Yeah, I mean, it was. It's really weird looking back, isn't it? Because it feels like a lifetime ago, and trying to remember. And one of the reasons for trying to write the book was to have a sort of almost contemporaneous record of what it felt like at the time. Because even now, I find myself, it's hard to imagine how we felt before it hit. And as you say, we were in huddles of people. In fact, we all came to the hospital to begin with to try and work out what to do. We'd have our office packed with people, half of whom caught COVID, obviously, from each other. I think one of the things that's interesting looking back is the difference between what we were expecting and what we got. So when it was building up, we were all about the risk to us, PPE and all that kind of stuff, and also the numbers. Was this going to be? Were we going to have 100 patients? Were we going to have 300 patients? Were we going to have 1,000 patients? And all that. It was all about the scale. And I think that was reasonable, because if you think, there was 100,000 people at Cheltenham, all these things were going on. We hadn't locked down. We'd seen Italy, horrendous. And then when it hit, it was a very different thing, because what we hadn't realized, it was just such an awful disease. And now, of course, we all know that, but it was the biggest part about it once it hit was that it was so difficult to treat. The patients were so sick, so complicated, so unpredictable, and it went on for weeks. And so it wasn't like polio, where you just shoved them in a bed and got a medical student to squeeze a bag. Each patient was pushing us to the limit, which is not very far in my case, as you know. So I think that was really shocking. And then as it, in the first few weeks, as the numbers kept going up, we were thinking, how long is this going to go on for? And every day it felt like we were on our last ventilator. And of course we never quite were, but there was that terrible fear of rationing and thinning the care, and how much you could thin it, and whether we should take people to the Nightingale. All these things happening so fast. And the other big thing, as I'm sure you know, when very quickly, was not having any relatives. So we take relatives for granted in the ICU, and you talk to them almost by osmosis because they're always there. You know, we allow them to be there all the time. So you're constantly talking and updating and getting information. Suddenly there were none. So although there were, 120 patients, there was no one by the bedside, which meant that we didn't have lots of information and they didn't have any information. And for the first couple of weeks, they couldn't get through to anyone. They'd ring the ITU and everyone was in PPE, so they couldn't talk to them, and it was an absolute shambles. And it was only when we realized that we needed to form a whole team just to look after families that we started to get a grip on it. So I suppose early on, those were our big things. And then as you know from the book, I had a real moment when in my first week, I think about my third day, a 28-year-old just completely fell in a heap and died in front of me, and that was not what it was all about. Meant to be sort of people in there, well, older than me anyway, with chronic health problems, and suddenly this guy of 28 who'd been fit and well just fell apart, and from then on it felt like a very different thing. Although that didn't happen very often. Thankfully, he was the youngest for us. But having said that, the second time round, of course, as we're seeing much more, or certainly this time, in this summer, with much more unvaccinated, quite a lot of them are young. Quite a lot of them are young pregnant people, or it's filtered out that people who aren't vaccinated. So we have seen more young people. So bizarre.
Looking back at the start of COVID, with hindsight, is there anything that one or two things that stand out that we might have done differently? Do you think when it hit the fan, as it were? Was there something where you think, God, if only we'd given them, chloroquine or something?
Oh yeah, no. Well, it's interesting, isn't it? I mean, not so. So it's an interesting question, because when we got the second wave in January, I thought we'd learnt loads and we'd be able to get them all better. Madly, I thought, oh well, we know what we're doing now. This will be fine. And of course, it wasn't. And in fact, the clinical changes we've made are actually quite marginal. We've got a couple of drugs that make things a bit better, but still, a good half of the ones that came to ITU died. I think what we did get much better at, and probably what has remained, is we're much better organised. So we used people much better. People were much happier generally the second time because they were doing jobs they were happy to do. We tried to make loads of people intensivists the first time round, and that was sorry about the bloke behind me. I'm going to have him fired.
Yeah, please do.
But we got much better at working the hospital. So the teams were really good. People come in, do a job, go away, rather than sort of hang around not quite knowing what to do. And I don't know I hope that was felt by all the people. I mean, of course, one of the great luxuries, or two great luxuries for us, one was that we never ran out of PPE, so we were never like the social care setting where we were putting bin bags on and stuff. And the second thing was that all of you guys came and helped us, and that was transformative. So because I think at peak we were turning 45 people a day, twice a day. That's an awful lot of manpower. So the fact that everything else stopped, I think, was saved us. If we tried to, and that's what's making it more difficult now. Obviously, we're trying to do everything, and that's very hard. So weirdly, not clinically. I mean, we went CPAP early, which I think was lucky, and turns out to have been quite a good thing to do. But otherwise, I don't think there's much, dramatic clinically that we changed.
And just taking that a bit further, what do you see in the next sort of 10, 20 years as being the biggest advances, say one in anaesthetics and one in critical care? What would you view as in the pipeline for us?
So it's so in anaesthetics, I think gases will disappear. I hope they will. That's already there to a large extent, but I think they'll go. I think they're like an internal combustion engine. Huh?
it'll be total intravenous anaesthesia sort of thing.
Yeah, for everyone. Most of us are doing that now. If you go to the Marsden, you can't. I don't think there is. Well, there might be one person might be using gas, but it's really, it's like electric cars, I think. And then they'll get really sophisticated on that. I think they'll be able to, that'll improve dramatically. I think in ITU we might, and this is a big might, but it's with I don't know if you know Jim Roberts. Do you know David Howard at ENT? So they're involved in developing a negative pressure ventilator again, which seems to be phenomenal. So you lie in it wide awake, and it's very transportable, and seems to be able to deliver very physiological, very comfortable ventilation. So potentially those.
Like the old iron lung, like the iron lung.
Yeah, except just over your chest, but exactly. Right. So we'll see, but possibly those two, I would, if I had to put my money on something.
And tell me, what's your fondest memory of your career so far, apart from meeting Alan myself? What's your fondest memory?
All my lists on a Wednesday, obviously. I think it's a slight cop out, but when I went out for, this is really depressing, but I went out for, we had our first ICU consultants dinner for 2 years the other day, and I realized that apart from Mervyn, I was the oldest appointment in the room, which was quite something. Right. But what was great to see was we from these sort of greats, like all the professors who are now in their sort of nearing retirement, we've built a place full of young people who I both like and am sort of in awe of. So that's really pleasing. And I think UCH has got that. I mean, I hope it has across the board, but it's a place, despite being a sort of lots of high-flying professors, it's still a very nice place to come and work. And I think that's not always the case in London, from what I understand, although I don't want to cast any aspersions. So I think that's
no gossip allowed.
Yeah.
So as a final question to you, Jim, thank you so much for your time. Just say that I was an undifferentiated second-year graduate Dr. FY2, not sure what I wanted to go into, but I was thinking about doing anaesthetics or thinking about doing intensive care. What advice would you give to me?
So I think it's you've got to, I mean, like all things, you've got to work out whether it suits you. There's an element to it that is bonkers in that, as I said, it's a high responsibility, low, well, anaesthetics, a very high responsibility, low power role. So the more invisible you are, almost the better. And that you need to go into with open eyes, I think, because that's, if you not expecting that, it's a bit of a surprise. And of course, this thing that, you don't make people better, you make them worse. On the other hand, it's very bottom up. So it's very back to physiology, and you can do things in real time. And there are lots of niches in anaesthetics that are really skillful these days. The airway guys, the pediatric anaesthetists, all that kind of stuff. In terms of ICU, I think one of the great selling points for me is that it's a proper generalist ward. So, they might all be at death's door or whatever, but they come from every specialty. So it gives you interactions. I mean, somewhere like here, there's a different professor in every day from some specialty. And that's a joy, because I'm constantly seeing things I've never seen before, and learning about diseases that only we're treating. So I think ICU really has that sort of generalist thing. It can be talking to you about a colorectal patient 1 minute, and then to a CAR T-cell hematologist the next minute, and I don't have to understand either of them, but I can learn. So that's I think that's the big draw of ICU. And some, not everyone has a bad outcome. Some come back, and in fact, writing the book was amazing from that point of view, because I actually got to meet some survivors 6 months and a year down the track, and that was really really wonderful, something we don't usually get to do. So I suppose that would be my pitch.
I assume I'm too old to transfer at this late stage. I'm joking, Jim.
I think we're interviewing next week, Richard.
I'm on the other side of the table these days, but it's been a real pleasure for me to get to know you over the last 17 years, and you haven't changed a bit from the day we first met as to your appearance. Whereas growing my hair's fallen out, so I'd like to know the secret another time. And I'm really grateful to you. Thank you so much for taking part in this webinar, and I look forward to working with you for another 17 years. I'm sure we'll be bumping into each other. So thank you very much. That was really interesting and entertaining. I really appreciate it.
Thank you, Richard. Thank you. Great pleasure.